Special edition of TopMedTalk here at the moment. This is part 2 of 2. And if you haven't heard part 1, well, you don't need to. This still makes complete sense. But it might be good if you check back on the podcatcher that you're using to listen to this podcast and find the previous edition of TopMedTalk. And then you can hear the first part of this piece. However, if you've never heard it, it still makes complete sense. What you're listening to is a special edition of TopMedTalk recorded at the Institute of Sport, Exercise and Health, live from an Enhanced Recovery After Surgery Leadership Forum. And they've been talking about how cold water adaptation can help people deal with medical issues. And we've been told there's evidence to suggest that cold water adaptation reduces inflammation. We've also been talking about hypothermia, never a good thing, and keeping patients and their environments warm. The contributors featured in this podcast include Dr. Simeon West, Consultant Anaesthetist at the University College London Hospitals, who sits on the board at Regional Anaesthesia UK, and Mark Harper, Consultant Anaesthetist at the Brighton and Sussex University Hospitals, with a research interest in the prevention of perioperative hypothermia, the use of cold water adaptation for therapeutic purposes. There are questions from the audience now, and it kicks off with a really fascinating question, I think. Have a listen to this. Monty Mythen presenting, of course.
TopMedTalk.
Hello, I'm Paul Hutchings, a consultant anaesthetist at the Norfolk and Norwich University Hospital in Norwich. I've got a more general question about facilities and resources for enhanced recovery after surgery. We are individually enthusiastic. We have 60 consultants. We have various packets of small areas of enhanced recovery that we've always done, but we're missing, we're losing momentum. I'm looking for ways to persuade our managers and service directors to help us to get more facilities. What sort of drivers are there to help us adopt more enhanced recovery after surgery facilities? Could it come from national bodies, or are there other sources? I heard some interesting information during our talk this morning for experience in the United States where it's coming close to practice standard to have enhanced recovery.
So I'll start with that one. So from the point of view of motivators, I think the best way to get people remotivated is to do a simple audit of your drink, eat, mobilise within 24 hours. You can do it as a snap audit, and if you just go and visit every patient roughly 24 hours after surgery for a week, for example, you can send somebody out there with a piece of paper and a pencil if you don't have an electronic health record, and just count up how many of your patients are drinking, eating and mobilising within 24 hours. And if it's over 90% of the patients, then you're not going to make a huge impact with regards to what we do perioperatively to improve their outcome. What you'll probably find is it's nowhere near the 90%. And that is the thing to take to management and to turn around and say, the data suggests that if we're not achieving that goal, we're not achieving the length of stays and the outcomes that would allow us to save this trust hundreds of thousands of pounds per annum. So why don't we re-examine what's happened to our previous enhanced recovery programs? And at the same time, the Getting It Right First Time team, led by Professor Tim Briggs, orthopaedic surgeon from the Royal National Orthopaedic Hospital, is championing this at the moment. So if he is contacted and his team are contacted, including the anaesthesia leads joint appointed with the Royal College of Anaesthetists, they'll offer help to support you to get whatever you need within your organisation to get people to accept that if they're not hitting those high rates of drink, eat, mobilise, and they're not hitting those length of stays and they're not hitting those outcomes, there's an enormous amount of money left on the table, and there's probably worse patient outcomes associated with it. So that would be my opening gambit. Before I come back to the question, have you got anything to add to that, gentlemen?
So my focus of interest is obviously the regional anaesthesia side of things, and we've made big changes in UCLH by introducing a block room, and yeah, it was a struggle in the first instance. In order to get funding for that, we went through the Health Foundation, which we're very pleased to get an award to try to demonstrate that it was a way of improving patient outcomes. And I think there's a good bit of work which Dr. Patel, who was talking earlier, has prepared for the Health Foundation in order to try and make that sort of thing scalable for individual trusts to try and show that improvement. So I think there are lots of bodies out there that, extra to the standard budgets that we've got, that we can try and tap into to try and get some of these things better for our patients.
I would say the stimulus from the perioperative warming perspective is a nice guideline. A nice guideline can be used as a stick to drive change and get organisations to comply.
Okay, yes, I would like to mention some of the things we have achieved where it just shows that it can be done. We have now invested money in a robotic laparoscopic prostate robot technique, which has driven that procedure down to 24-hour stay. But we're missing things like same-day major arthroplasty, where we were doing very well, got down from 5 days to 3 days stay, and now it's stalled, where I know from quality improvement for surgical teams meeting up in Northumbria, they're regularly doing 1 day joint replacement work. If we have a packet of procedures, we have a laparoscopic assisted nephrectomy is enhanced recovery, but if it's a partial nephrectomy, it's not. There are strange paradoxes. We need more facilities for preoperative assessment, technology for fluid management to optimise that. I just appreciate the help that you've given to find ways that we can get our managers on board for this, and the audit, I think, is a good start. Thank you.
And I think the key thing which the Getting It Right First team will help with is increasingly dashboards are going to be sent out with data for all of us to look at and be aware of. And it lets us have a clear understanding of the enormous amount of resource that we're leaving untapped. And most of that does relate to getting the patients, getting it right first time, getting them prepared and getting them out of hospital as quickly as is possible and getting them home and not readmitting them. And it's probably one of the few ways that we can free up a lot of resource and beds to keep the health system improving. Now I know we had some more questions or comments. Here we go, sir.
I've got two questions. I'm Dr. Jitendra Garg from Queen's Hospital in Romford. First question, I do an orthopedic list, and most of the time when I'm trying my patients to convince for regional, most of them say with the word go, epidural, spinal, no. So how to convince these people? Have you got any techniques where you say, I think more than 60-70% of the patients are with the word go. They say, no, we do not want it, nothing in our back, please. And my second question is, I think when you were giving the lecture, you said about high dose opioid. So I want to know what is the dose as a high dose. I'm presently using about 400 mics of dimorphine. Is there any other dose which you use for spinal?
Okay, so thanks for your question. I'll address those in turn. Convincing patients to have central neuraxial blocks. I think it's very easy once you've done it and they see the results and they wake up in recovery pain-free, they know they've made the right choice. So it's trying to get those patients to come back and advocate for that technique, to the joint school and to the ways that you're pre-assessing the patients, so that they've got something to reference, patient videos, and a consistent message coming through right the way from booking, orthopaedic clinic, right the way through to joint school, and then pre-assessment as well, that it's the normal to have a spinal or epidural anaesthesia for your major joints. And then on the day, your job is that much easier because they already appreciate that that's going to be the technique of choice. There are obviously some patients that are still going to choose a general anaesthetic, and we don't want to take away agency from patients in any way. But I think from a evidential base, there's absolutely no study out there that's ever proven that regional anaesthesia has a worse outcome than general anaesthetics. The But there's certainly plenty of signal and noise to suggest that regional anaesthesia has a positive benefit on post-operative outcomes, especially respiratory and thromboembolic events post-operatively. Regional anaesthesia for central neuraxial block has a positive benefit, and that's been proven in large-scale database studies over in the States, and on a smaller scale over here. So I think that's my message, is always that this has all the added extras of great analgesia, and but also has some positive benefits. I guess the other aspect of it is what is it that the patients are dreading about the central neuraxial block, and it's usually, am I going to hear the surgery? Am I going to see something that I don't want to see? And actually, most patients who do stay awake, they find that the engagement with the surgeons and the ability to see what's being done is actually really helpful, because it's positive reinforcement that what they expected is going to happen is going to happen. It's much less worse than they thought it was going to be. But those who do have sedation, our modern techniques of sedation are such that we can keep a patient amnesic throughout theatre, and so we can reassure them that they're not going to remember anything from the surgery if that's the method that they choose. And actually, so second question, so dose of intrathecal morphine. I mentioned that there are pockets in the country who are doing higher dose intrathecal morphine. We have, as part of our cystectomy pathway at Westmoreland Street, we use a higher dose than standard of diamorphine, up to 1 milligram of intrathecal diamorphine. And but all of those patients are going to a high dependency unit, because as you start to go up in the doses, you will see some post-operative respiratory depression. Morphine obviously much greater than diamorphine, and so I think if you're going much more than 400 or 500 micrograms of diamorphine, you need to be putting them in a monitored environment. And certainly if you're considering using intravenous opiate on top of that, then you need to be in a monitored environment. But I don't think there's an evidence base out there yet. There is certainly pockets of people doing it, and I've heard of people using up to 1.5 milligrams of diamorphine intrathecally for colorectal surgery and the like. But I think the evidence needs to be there that that's a safe technique as an alternative to a regional block. And I think my personal feeling is that if you're looking to extend the analgesia of the intrathecal opiate, it's a great place to put it. But why not supplement that with a local anaesthetic block that then gives you that additional analgesia too?
My name is Vishal Patel. I'm a consultant anaesthetist in Cambridge. I've got two questions. The first one is there a hierarchy among the various elements of the enhanced recovery pathway? Are some elements more important than others? And the second question is for Mark. Is a nice cold shower a good enough substitute for cold adaptation?
So two great questions there. The hierarchy of enhanced recovery, which is a commonly asked question. Can you please tell me what is the secret sauce? What do I have to do and what do I not have to do? And that takes us right back, I think, to Professor Kellett's original 4 columns. You do have to put a lot of energy and effort in preparing the patient, managing expectations, mitigating as much potential harm as possible by addressing things like anemia, diabetes, exercise tolerance, lifestyle habits, etc. So that's a must-do thing. And as I said, also managing that expectations, i.e. we do want you to move straight away afterwards. We will be asking you to eat and drink straight away. It is going to hurt. We are going to give you pain relief to make you as comfortable, we don't try not to use the P word, as possible, to allow you to achieve the goal of mobilising, which is really important for you not to get complications. So that has to be done. Then the only other things that really have to be done is you have to do that drink, eat, mobilise. So you must get people drinking, eating immediately post-operatively. You must get them standing up and walking around within 24 hours. Pretty much everything else is negotiable. So although we are trying to be opioid sparing or opioid free, many people have very successful enhanced recovery programs that use a fairly traditional dose of opiates. Although some people feel very strongly about the constituents of the preoperative drink, Some people have great enhanced recovery programs using water or lemonade. So almost everything else is negotiable. Everyone agrees the surgery should be as minimally invasive as possible. Everyone agrees you have to deliver a pain management regimen that minimises nausea and vomiting and facilitates the mobilisation. And everyone agrees you have to get the fluid management right. But to say it one last time, preparation and achieving the objectives of the drink, eat, mobilise, almost everything else is negotiable. But once you've agreed what your pathway is locally, you have to do it consistently in almost every patient. And the only deviation from the pathway to be successful should be because of patient need, not provider opinion. And then when you do deviate, you need to document it and communicate it to the patient, i.e., in your individual situation, it was not right, in my opinion, to give this drug. Therefore, I deviated in your best interest, and I've communicated that with you and the notes and the team. It's a long answer, but from the point of view of the reassurance about the secret sauce. Now we can go to the more interesting, but maybe not as practical question, which relates to, can a cold shower do the same thing?
The study has been done. And the answer is no, it's not as effective. And the reason for that is there are two elements to cold adaptation. One is the absolute temperature you go into, and the other is the rate of cooling. And if you, in a shower, although the temperature might be the same, the rate of cooling is less. So that's why it's less effective. So it will be effective, but it's not as effective as full-on immersion.
Bonamurthy, one of the consultants from South Wales. Recently, I was listening to one of the orthopedic surgeons, and he was suggesting the way forward is doing the knee replacements without tourniquet in ERAS pathway, and he strongly believes in that. And I haven't seen that. Do you have any experience about that?
Yes. So yeah, interesting question. We moved over to not using tourniquets with our total knee replacements a couple of years ago, and certainly so we still put the tourniquet up just prior to cementing. So it's put on underneath the drapes. It's all sterile, and then but we only inflate it just prior to cementing, and then after cementing, the tourniquet comes back down. And I have to say, I think there is less pain as a result of that technique. You know, the vast majority of our patients are done under a spinal anaesthetic, but regardless on that, the longer term pain it seems to be better. I don't have scientific data to back that observation up yet, but I do think it's a valid technique. The only thing I would with the one proviso is, when the surgeons then go to use infiltrative anaesthesia at the end of the case without a tourniquet, you've got to be very careful. If in a bloody field there is adrenaline in that mixture, sometimes you see some systemic effects from the adrenaline. So I think it's probably best to have the tourniquet up still then as well.
Well, saying that, I sort of talked from a Danish orthopaedic surgeon, and his take was he looked at a lot of myths surrounding orthopaedic surgery. And one of the ones that he busted very effectively was the fact that putting a tourniquet for knee replacements doesn't actually reduce blood loss. There's no
you don't need it at all.
So theoretically, you don't need it at all yet. And they have more pain. As you say, the pain from the tourniquet is so significant.
Yeah, and also the release of the tourniquet as well, if you've had it for the entire case, is quite a significant ischemic hit.
Yes.
Hello, Paul Hutchings, Consultant Anaesthetist in Norwich. Another question. We have an increasing number of frail and elderly patients coming through our service. Is there evidence beginning to be seen that the choice of anaesthetic technique and indeed the adoption of a enhanced recovery program can change the high instance that we're already seeing of post-operative cognitive decline?
So I think that is certainly an area of great research interest. My personal view is that we do see an increased risk of post-operative cognitive dysfunction in the elderly having hip replacements under general anaesthetic. But I think that's probably to do with blood pressure control rather than the methodology. My high horse is always do a spinal, because the spinals cause less hypotension than the general anaesthetics in most people's hands, especially if we drop the doses of the spinal anaesthetics, and that should have a knock-on effect on postoperative cognitive dysfunction. The other aspect of that is multiplicity of drugs for turning the patients to do the spinals as well, and I think the SNAP audit certainly showed some patients were getting 4 different sedative agents prior to having a spinal, and that can only be a bad thing. But I think the work isn't there to prove absolute causality.
So I think this is not my specialist area, but looking at the literature on a regular basis, the associations are getting clearer and clearer. Mm-hmm. There's less evidence at the moment from prospective randomised control trials, but when I hear enthusiasts talk about this, they've gone to all the trouble of risk rating somebody, they've identified that they're at high risk of having cognitive dysfunction post-operatively. The spinal is given, but it's the adjunct therapies that undo all of the opportunity.
Absolutely.
It's the little bit of benzodiazepine, it's the little hits of X, Y and Z.
Absolutely.
Which really, why did you sort of bother? Because now you've undone it all by giving all those meds. Is that fair?
Absolutely. So we have a protocol for all our HIPs, which involves having a fascia iliaca block at least half an hour before they have the surgery, before they have the spinal, and I think that mitigates the need for the vast majority of adjuncts prior to turning. And then if we are to use something short-acting like propofol, I think is the ideal agent for prior to turning. So it's pretty much gone before the end of the spinal. And then the spinal does all of your work. Once the spinal's in, that patient's likely to fall asleep anyway. They really don't need another sedative after that. So we've been driving that protocol forward over the last couple of years, and we've seen the adoption of the technique come right up, and I'm consistently getting my colleagues who suddenly find themselves on the trauma list going, okay, there's a protocol, I followed it, I was really surprised when it really worked, which is great to hear, because obviously it's all anecdotal. I take that as a point, but I think it's one of those things when you see it work, you suddenly become a bit more of a believer.
Great stuff. Well, thanks. Our time is up. Any final comments as we go? Mark, anything to take home?
Warm your patients. Warm them more, and warm them before they get cold.
Pre-warm them, warm them, keep them warm.
And use more than one technique to keep them warm intraoperatively.
But being cold can be good for you under some circumstances. Watch this space.
Being put into a cold water can be good for you, but actually being hypothermic is always bad.
Okay, gotcha. Sim,
my take-home message is use some local anaesthetic in whatever way you feel safe and comfortable in doing it, but make sure local anaesthetic is part of your enhanced recovery protocols.
Okay, and mine would be that we know more about fluid management than we've never ever known before. Next week, if you listen to our main journal club, we'll be doing a deep dive on the recently published relief trial with Professor Paul Miles, who's over visiting in London. So we're going to be going that into some detail. So please keep your eyes and ears peeled for that. So thank you very much indeed for everyone for joining in. Thank you for listening into TopMedTalk. Please do visit our website, www.topmedtalk.com. Our podcasts are all free. Please do come to another one of our meetings. Today was organised by Evidence-Based Perioperative Medicine. Our website's www.ebpom.org, trying to bring the best education at the lowest possible price to the world. And thank you very much indeed to Smiths Medical for sponsoring today. So travel safely and have a wonderful weekend.
Thanks for downloading Top Med Talk. That was part 2 of a 2-part piece. If you haven't heard the first piece, why not go and have a look? How would I do that, Nick? I'll tell you. Subscribe to topmedtalk.com.